For the moment, we are still searching for important biological pathways that we can target. One of the efforts that we are conducting for the moment is to try to understand how BRAF-mutated tumors are working and how we can combine treatment options to have a better outcome for these patients with a poor prognosis. So that's one part of the story. The other part of the story that we are looking for combination strategies to combine immune therapy with standard chemotherapy or with other types of biologicals to have a better outcome, especially in the MS stable patients. So it's clear that if you look back to all the data that we have available, that there is a difference, especially in metastatic colorectal cancer, but also in early colorectal cancer, a difference between the left and the right-sided located tumors. The left-sided tumors are doing better than the right-sided tumors. We don't have a clear answer how this happens, but probably it's an interplay between the microbiome, between the genetics, which is different at the right side versus the left side. But this is consistently seen in every retrospective data set that we have available. Yeah, we made some progress. If you look back 10 years ago, almost nobody did some biomarker analysis in our patients with colorectal cancer. Then we had the first step with performing KRAS, then extended RAS. Then on top of that, we had the integration of BRAF in our molecular-based evaluation. Otherwise, we had some interest now with the link towards immune therapy with MSI. And for example, in end stage, also HER2 determination might play a role in guiding our decision towards therapy, but also understanding what is the prognosis of an individual patient. The reason why we can do this today is also progress made in the technology. NGS is now easily accessible, the cost is coming down, and we moved from tissue to liquid biopsy, which gives an information that we can obtain at different time points during the disease of our patient. So clearly we made some progress, but for the moment it's still work in progress. The final answer for the different groups of patients need to be evaluated, and further research is necessary. For the moment, if you look to all the drugs that we have available, most of the RAS wild-type patients can have different treatments during the evolution of the disease. That is the reason why, for the moment, the median overall survival in that patient population is above 40 months. One of the groups that has a problem is, for example, the RAS mutant population, where you don't have good additional drugs on the standard chemotherapy that we are using. Another group, like I already said, is the BRAF-mutated tumors, the V600 specifically. Also there we are still in research to have an impact on the bad prognosis of these patients. So there are subgroups for the moment who are doing poorly, and we need absolutely more drugs available, probably based on the molecular profile or on the profile overall. Not only molecular, but for example, proteomics might play a role in the near future. I think the most important for the field of colorectal cancer is that we have seen in subgroups new ideas, new hypotheses. We have some trials who are running for the moment, and for example in the BRAF-mutated patients that showed some nice results which might influence our treatment strategy in the future. And another part of this ESMO meeting is that it's not only European research but also Asian researchers which are doing a lot of work, and we need to combine this information to get a good prognosis for our patients.